Hi class, in this lecture we will review drugs for the treatment of allergic rhinitis, cough, and cold. For this lecture, the objectives are listed in Blackboard, and there are no new vocabulary terms. So let's discuss allergic rhinitis first. This is the most common allergic disorder, and it affects as many as 10 to 30% of the population. So allergic rhinitis is an inflammatory disorder. It affects the upper airway and the eyes. Symptoms of allergic rhinitis include sneezing, rhinorrhea, pruritus, nasal congestion, and in some folks, they'll even experience conjunctivitis, sinusitis, or even asthma. The symptoms are triggered by airborne allergens that can be either seasonal or perennial. The seasonal allergens is typically what we call hay fever, and this results from pollen or fungi from weeds or grass or trees or other kind of outdoor sources or seasonal sources. Perennial allergies, on the other hand, are triggered by indoor allergens. And so when you think of the indoor allergens, things like dust mite dander or feces, pet dander tend to be the common causes. So these allergens bind to IgE, or immunoglobulin E, specifically on mast cells, and that's what causes a release of inflammatory mediators like histamine, leukotrienes, or even prostaglandins. So the drugs that we use for allergic rhinitis, I think when you take a look at these, they make sense. Glucocorticoids, we haven't talked about this drug class yet. We'll talk more in depth about this drug class in a couple weeks. For this lecture, we're just going to talk about the intranasal preparations of glucocorticoids, but I say they make sense because those drugs decrease inflammation. Additionally, the antihistamines are used to treat allergic rhinitis, and I mentioned a few moments ago that when IgE binds to mast cells, one of the chemical mediators that are released is histamine. And so I think it makes sense that antihistamines would be used for allergic rhinitis. And then finally, decongestants. So I mentioned the symptoms of allergic rhinitis, one of which was nasal congestion, stuffiness. So the decongestants are used for that symptomatic therapy. So let's start by talking about the intranasal glucocorticoids. The prototype intranasal glucocorticoid is mometasone, and the brand name is Nasonex. Now, you may have heard of others. I believe there are maybe 6 to 7 other intranasal glucocorticoids on the market. There's a chart in your book if you'd like to take a look at those. But some of them you may have heard of. I'm sure some of you have heard of Flonase or Nasacort. These are the brand names. And there's a lot of direct-to-consumer marketing for these drugs. So these are definitely drugs that patients ask for, and there are drugs that are prescribed. Now, these drugs are actually the most effective for the treatment of seasonal allergies of all of the drugs I'm going to talk about. So for that reason, they really are considered the drug of choice for rhinitis, allergic rhinitis, which is basically manifesting in kind of the nasal cavity. Over 90% of patients who get these medications respond, and several of these medications are OTC, so patients can actually just go to the pharmacy and pick these up on their own without a prescription from a prescriber. They work through their anti-inflammatory actions that suppress the allergic rhinitis symptoms. In terms of adverse effects, there are some adverse effects that are associated with these drugs. They can cause sore throat, nosebleed. It can cause headache or even a burning sensation in the nose. So for the most part, these adverse effects are kind of local to where the medication is administered. They can also, I just want to mention this, I realize it's not on the slide, but I just want to mention it. Rarely, they can also cause adrenal suppression or even slowing of the linear pediatric growth. This is extremely rare. And generally, if those serious side effects occur, it's because the patient is exceeding the recommended dose. and they're absorbing additional drug into the systemic circulation. So, like I said, those are very rare. We'll talk more about adrenal suppression and slowing of linear growth for kids when we talk about the glucocorticoids in general in a couple weeks. But for this preparation, I would say focus on those local adverse effects that I have listed on the slide. In terms of nursing implications, patients need to be educated that these drugs should be used daily. So this is not a PRN type of med that you only use when you have symptoms. These drugs do take a little time to work. For the most part, if the patient's using it for allergic rhinitis, generally they take about a week to work. But if the patient has perennial allergies, those can take up to several weeks to work for these drugs to work. So definitely letting patients know that this is a daily drug. It is intranasal, so it's a metered dose product that they're going to squirt into their nose, and they have to take it regularly, and it's going to take a little while before it actually starts to work and relieve their symptoms. But once it kicks in, these drugs tend to be very effective, and most patients experience relief with these medications.
So let's discuss the antihistamines. We'll start with the first generation H1 antagonists. Our prototype is diphenhydramine or Benadryl. I'm sure you're all very familiar with that medication. It is available over the counter, as most, or I should say many, of the first generation H1 antagonists are. It is widely used, both in the United States and around the world. It blocks the action of histamine at H1 receptors. And histamine, like other compounds, plays a role in allergic reactions. Mild reactions, like rhinitis, itching, localized edema, those are in many cases the result of histamine binding at those receptors. So diphenhydramine is pretty effective at mediating those symptoms. Of note, these drugs do not block H2 receptors. So other drugs that are discussed in this course include the H2 blockers that are used for peptic ulcer disease and GERD. Those receptors and the H1 receptors are a little different. So these drugs do not block those receptors. The therapeutic uses, so just kind of general allergic rhinitis, motion sickness, nausea. We've talked about drugs in this course for motion sickness and nausea. And some of those drugs were actually antihistamines, specifically promethazine. Promethazine is considered a first generation antihistamine. It also has activity at blocking dopamine receptors, but nevertheless, it is actually an antihistamine. So insomnia, so these drugs cause sedation, so they are used quite frequently for insomnia. In fact, many over-the-counter sedation medications or insomnia medications contain Benadryl. And then they're just used for the common cold. So in terms of adverse effects, by far, sedation is the primary adverse effect of concern. If any of you have used Benadryl before for allergies, you know that it has a tremendous capacity to cause sedation. Some people have difficulty waking up the following morning. It does tend to produce some daytime drowsiness, which can be a problem for some patients. It also has non-sedative CNS effects as well, like dizziness, fatigue, confusion, things like that. Can also cause GI problems like nausea, vomiting, loss of appetite, constipation. And generally, we avoid this drug in pregnancy and lactation because it does cross the placenta and it does cross into breast milk. In terms of drug-drug interactions with the H1 antagonist, first generation H1 antagonist, the major one we worry about is CNS depressants, and this is due to a pharmacodynamic interaction because both CNS depressants as well as the H1 antagonists can cause sedation. And so that sedation can be additive if the exposure to either or both of the drugs is high enough. So we would be concerned with any medications that cause CNS depression or even alcohol, which is also considered a CNS depressant. Safety concerns in general, this drug has a very wide margin of safety. However, due to the widespread availability of this drug, we do see cases of acute toxicity with the first generation H1 antagonist, specifically Benadryl. In a toxicity scenario, patients will generally have CNS toxicity, extreme sedation, some of those other CNS effects I talked about, as well as anticholinergic reactions. Because again, this medication can can block not only histamine receptors, but it can also block it can also block muscarinic cholinergic receptors. And so that's why we see anticholinergic effects at normal doses, but we can also see anticholinergic effects in a toxicity scenario. So in terms of treating these toxicities, if the drug was ingested recently, then we can attempt drug removal via activated charcoal or cathartics to remove the drug from the GI tract. But for the most part, it's just supportive therapy. So nursing implications really revolve around preventing adverse effects. So taking the dose at night, again, it causes sedation. So if the patient's about to go to sleep, that would probably be the best time to take the medication. Avoid driving in hazardous activity. I would even caution patients that when they first start taking this, that they should see what the effects are for them and determine whether or not they're able to drive or perform other hazardous activities. Some patients have occupational jobs that involve hazardous activities, so those patients should be warned. Obviously, avoiding alcohol and other CNS depressants, and then you can teach your patients methods to minimize anticholinergic side effects, and we've talked about this throughout the course. The anticholinergic side effects seen most frequently with therapeutic doses of antihistamines is dry mouth. So one way to help patients minimize that is through the use of sugar-free candy or drinking a lot of water throughout the day. Most of the other anticholinergic effects we don't usually see at therapeutic doses, but nevertheless you could warn patients about those as well.
Okay, so let's move on. We'll talk about the second generation H1 antagonists. The prototype is fexofenadine or Allegra. I am sure you guys have heard of all the different second generation H1 blockers or H1 antagonists. Allegra is our prototype, but others you may have heard of, cetirizine or Zyrtec. You may have heard of loratadine or Claritin, and there are a couple others on the market. These drugs are extremely popular drugs. They're very effective, and luckily they don't have a lot of side effects. So they're actually almost like an ideal drug in some respects. They're not perfect, but in many respects they're pretty good drugs in terms of their therapeutic effectiveness and the fact that they don't cause a lot of adverse effects. They're used for allergy, just like the H1 blockers, mild to moderate allergy symptoms like allergic rhinitis symptoms. They can also be used for chronic idiopathic urticaria, which is an allergic type reaction of unknown origin that it's not sure kind of how it's happening or why it's happening, but basically the patient is thought to have an allergy to some specific allergen like a dye or maybe some kind of indoor allergen. And unfortunately, the patient keeps experiencing this over and over and over again, and it's difficult to figure out what the source of that allergy is. But these drugs are specifically approved for the treatment of that and basically for prevention of those allergic responses. So these drugs, like I said, are well tolerated for the most part. A couple things to point out between the first generation and the second generation drugs. The main difference between the first generation and second generation H1 antagonists is that the second generation drugs really don't cross the blood-brain barrier, and they have a low affinity for the H1 receptors that are specific to the CNS. So they really don't cause the CNS problems that the first generation agents like Benadryl cause. So they're not going to cause sedation. They're not going to cause those non-sedative CNS problems. These drugs also don't activate cholinergic receptors to the same extent that the first generation drugs do. So for the most part, we don't see anticholinergic side effects with these drugs. So these are two really good reasons why the second generation drugs are preferred over the first generation drugs, specifically for the treatment of allergy. Now, you may have noticed as I was talking through kind of how these are different, you also may have noticed that the therapeutic uses are different, right? We're not going to use these to treat nausea or insomnia, again, because they're not having those CNS effects. These drugs can interact with fruit juices, different types of fruit juice. The juices can actually impact their absorption. So it's recommended that these drugs aren't administered with fruit juice. Patients should take them with water, basically. If they do drink juice, they need to separate the juice from the administration of the medication at least 4 hours before the antihistamine is taken, or a couple hours after that dose. Originally, when these drugs came on the market in the late 90s, they were prescription only, but they are all now available over the counter. And so patients are able to, recognize that they've got allergic rhinitis symptoms and go to the pharmacy and just purchase these drugs for the treatment of those symptoms. All right, and the last antihistamines we're going to talk about are the intranasal antihistamines. The prototype is azelastine or Astelin. These work the same way. They block the action of histamine at the H1 receptor. They are used for allergic rhinitis, and they don't really have a lot of adverse effects. They can have somnolence if the patient is taking more than what's recommended. So if they're taking lots of squirts of this medication throughout the day, and they should only be taking it twice a day, but they're doing it kind of, every couple hours, or they're using several squirts instead of what's recommended, the drug can actually be systemically absorbed. There is pretty good blood flow in the nose, and systemic absorption can occur through the nasal mucosa. So somnolence is a possible side effect, depending on whether or not the patient is following the directions. These drugs can also cause some local effects like nosebleed or an unpleasant taste in the mouth, and they can also cause anticholinergic effects. Again, more likely if they're taking more than what's recommended because of that systemic absorption. But these drugs are used intranasally kind of for that local effect in the nose. All right, and the last drug that we'll talk about, the last drug class that we'll talk about for allergic rhinitis are the decongestants. And so the prototype decongestant is phenylephrine. The brand name is Neosynephrine. I'm sure you guys have heard of this drug before. It's a very commonly used medication. This is an over-the-counter medication. Its mechanism of action is that it activates alpha-1 adrenergic receptors, specifically those on the nasal blood vessels. And so what that does is it reduces inflammation in the nasal, it causes vasoconstriction, first of all, which you guys should all know, right? So activation of alpha-1 receptors on vessels in the body causes vasoconstriction. Now these vessels, these particular blood vessels are in the nose, and so when you vasoconstrict, that's going to reduce inflammation and reduce nasal congestion. These drugs do not have any effect on reducing sneezing or itching or any of those more allergic type reactions. This is really just reducing nasal congestion due to the decreased inflammation and the vasoconstriction. So adverse effects, so with the topical forms, and so just so you know, these drugs are available both topically and orally. The topical preparations are pretty effective. They work very quickly. The problem is, if you use the drug too long, the patient will experience rebound congestion. Basically, the blood vessels in the nose, the body kind of compensates, and the effect that was initially seen with this reduction in inflammation, the body overcomes that. And so these drugs really shouldn't be used for more than a couple days topically. The oral preparations don't cause rebound congestion, but those preparations really aren't as effective as the local preparations. So rebound congestion is an issue with the topical form. CNS stimulation, this is more of an issue with the systemic form, the oral medication. But like I said, those drugs don't really work all that well. At least phenylephrine doesn't work all that well. So the CNS stimulation is a concern, but because the drug has a pretty high first pass effect, it may or may not be seen. It depends on the patient. Cardiovascular effects and stroke also are possible effects. Typically, those are associated with the oral form. And by the way, CNS stimulation, cardiovascular problems, stroke, these could be seen with the nasal form if the patient is overusing the medication. If they're using it constantly, not following the instructions, it is possible for those effects to be seen. And then abuse potential. I want to mention this. This really isn't a big issue with phenylephrine in particular, and phenylephrine is our prototype. However, there are other decongestants in this drug class, like pseudoephedrine or ephedrine. You may have heard of those products. Pseudoephedrine, the brand name is Sudafed, so it's a pretty well-known medication. There is the potential for abuse because these drugs can cause kind of like a stimulative effect, kind of like an amphetamine-like effect. And so because of that, at least in Maryland, these drugs have to be kept behind the pharmacy counter. So if a patient needs Sudafed or wants to use Sudafed, they have to present their ID. This is scanned. There's a whole process in place. The patient's usage is tracked kind of across pharmacies, not just at one specific pharmacy, because of that abuse potential. These drugs can also be used, Sudafed specifically and ephedrine can be used in the production of methamphetamine. So that's another reason, obviously, why those are controlled in a different way than other over-the-counter medications. All right, and let me just finish up with individual variation. So in general, these decongestants are avoided in patients with any type of coronary artery disease, hypertension, because they can worsen those conditions, and also chronic rhinitis, again, because they can worsen that condition. Nursing implications, making sure that patients are educated on how to administer these medications would be important. They do, the topical form is available as drops or as a spray, like that, where you, like a metered dose type spray. And so making sure educating patients on how to use those different dosage forms is important. For example, with the drops, patients should be in a lateral position with their head low, and that this is to help increase the likelihood that the drug's going to be absorbed in the nasal mucosa and not actually just kind of swallowed by the patient, because then it won't be as effective and it can also cause systemic issues. And then finally, education. So some things you might want to tell patients if they're going to be using these medications. Topical works pretty quickly. So relative to the oral medication dosage form, the topical works pretty fast, but it doesn't last as long. And then the other very important thing, which is bolded on your slide, use of the topical preparations should not go on for more than 3 to 5 days because there is a risk for rebound congestion. Systemic use does not lead to rebound congestion, as I already mentioned. However, it can lead to vasoconstriction. And so that vasoconstriction can be problemsome for certain patients. So if you've got patients who have hypertension or patients with coronary artery disease, they should be educated not to use decongestants. And then even for the topical forms, if the patients are using very high doses, that can also lead to vasoconstriction and problems for certain patients. So these patients should be educated to follow the directions. Only use this medication as directed. All right, so let's move on to the treatment of cough and cold. So cough is a pretty complex reflex. It involves the CNS, the peripheral nervous system, as well as the muscles of the respiratory system. Cough is actually beneficial. So there is a reason why we cough. For the most part, it is to remove excess secretions from the bronchial tree caused by irritation of these excess secretions. Now, in some cases, cough is not always a helpful thing. So for patients who have a non-productive cough, which again can be caused by irritation associated with the common cold or other respiratory infections, this can create problems for the patient, can cause discomfort, sleep deprivation, and for that reason, it is sometimes appropriate to treat a non-productive cough. So I've already mentioned common cold as being one of the main reasons for cough, but just so you know, common cold is just a result of an acute upper respiratory viral infection. In most cases, I think the statistics something like 50 to 80% of all common colds are caused by the rhinovirus. So causes nasal congestion, cough, rhinorrhea, sneezing, sore throat, and so forth. All symptoms that I'm sure all of you have had at some point in time. In some patients, fever is also associated with the common cold, usually in kids, not so much in adults. The good thing about the cold, because it's a viral infection, it's usually self-limited. It doesn't last very long. It's usually somewhat benign. And there is no treatment. So there's no antiviral drug that's available to treat the common cold because it's usually self-limited, because it typically doesn't cause long ongoing problems. Really what we do is we just treat the symptoms of the cold. So there are several drugs that we could use for cough and cold. Antitussives. Basically, there are two groups of antitussives. There are the opioid antitussives or the non-opioid antitussives. And then the other class of drugs are the expectorants. So let's talk about each. All right, so let's talk about the antitussives, specifically the opioid antitussives first. So first of all, antitussives are drugs that suppress cough. Some of these act within the CNS. Both of the prototype drugs we're going to talk about act in the CNS, but other antitussives can act elsewhere. The mechanism of action for the opioid antitussives is that they suppress cough through binding to opioid receptors in the CNS. And so the use of these drugs specifically as an antitussive, they will suppress cough. And they're actually pretty effective at suppressing cough. However, there is not necessarily good evidence that the cough that's associated with the common cold, that they suppress that kind of cough. But nevertheless, they're commonly prescribed for cough associated with the common cold. The prototype that we will talk about is codeine, and you guys should remember codeine. We talked about codeine when we talked about pain, and hopefully you remember that these are one of the drugs, opioid drugs, that we try to avoid. And that is true. We try to avoid codeine. It's not necessarily all that effective for pain management. However, it is used, when it is used, it's more likely that it would be used as a cough suppressant. Adverse effects. So the drug can cause CNS effects, of course, because that's where it's a centrally acting drug. Can cause nausea, vomiting, constipation, other kind of GI issues, and that is due to binding at different types of opioid receptors. Can cause respiratory depression. Now, with the doses that are used to suppress cough, we generally don't see respiratory depression, but it can be seen. And of course, if the patient overdoses, either intentionally or accidentally, then of course the patient would be at risk for respiratory depression. And there is an abuse potential for codeine. Even though it's not necessarily a great pain reliever, it can cause euphoric feelings in patients, especially if they're taking the medication at high doses. So there is that abuse potential. So this drug is prescription only. It is a controlled substance. Depends on the formulation, whether it's a Schedule 2 controlled substance or whether it's a Schedule 5. And the Schedule 5 product has a pretty low concentration, and it's used in combination with other medications that treat cough and cold. So those tend to be Schedule 5, but when it's codeine on its own, that's a Schedule 2. In terms of safety, the main concern is the risk for overdose. So if a patient overdoses on codeine, that can lead to respiratory depression and ultimately death. The dose, so I've mentioned this, the dose that's used for as an antitussive is pretty low. And in fact, it's only about a tenth of the dose that you would need if you were actually treating pain. So while the dose is low and while the preparations that are intended for cough suppression are of a lower concentration, there is still that risk that a patient could be overdosed. The risk of physical dependence is also small, just to mention that, because of the nature of the use and the fact that small doses are being used. Nursing implications. Patients should be educated to avoid driving and doing other hazardous activities, given that these drugs can have CNS effects like sedation. They should change positions slow because of the risk of orthostatic hypotension, and then avoiding alcohol and other CNS depressants because codeine has CNS effects. So some of these nursing implications, these are things we've already talked about with opioids in general. The discussion here is really focused specifically on the use as a cough suppressant. And again, really what you see is lower dose therapy, less likely to see some of the side effects, but there is still a potential for those. Most concerning thing being the potential for respiratory depression. All right, so the next drug that we'll talk about is also an antitussive, but it's a non-opioid form. The prototype is dextromethorphan, brand name Robitussin. There are hundreds of different products that dextromethorphan is in. Robitussin is just one of them. Robitussin itself could be a single ingredient drug. It could have other ingredients like Tylenol, phenylephrine. It could have antihistamines. So patients really need to be educated if they're going to use these over-the-counter products like dextromethorphan that can be combined with other ingredients. Mechanism of action, it suppresses cough through actions in the CNS. This drug is derived from an opioid, but it's not considered an opioid. So structurally it's similar, but it's not actually activating opioid receptors in the brain. There's no risk of physical dependence with this drug. And the risk of patients experiencing euphoria at therapeutic doses is very low, in fact, probably non-existent. However, in high doses, patients can have experience euphoric feelings, even have hallucinations. And so this drug is, because of that, this drug is abused to some extent, unfortunately. The adverse effects are pretty minimal. It can cause some dizziness. Probably the most profound thing that this drug can cause is sedation. It can also cause nausea. So because it can cause sedation, patients should be educated to avoid driving and other hazardous activities until they are clear, how the drug affects them. And they also need to be educated to read over-the-counter labels very carefully. I mentioned already that dextromethorphan is contained in upwards of 150 different products in the United States. So there could be any number of other ingredients also in those specific products. So patients really do need to be careful when they're taking cough and cold preparations like those that contain dextromethorphan so that they're not using medications that have other ingredients that they shouldn't be taking, or maybe that they're already taking separately, and so on. So reading OTC labels is a very good education point for these medications.
The second non-opioid antitussive is benzonatate or Tessalon. Some of you may know of this as Tessalon pearls. This drug acts by suppressing cough through its ability to decrease the sensitivity of respiratory tract stretch receptors. This drug is actually structurally similar to tetracaine and procaine. These are both local anesthetics. But ultimately, they're affecting the cough reflex pathway. And so that's, ultimately how they're suppressing cough. The only use for this drug is for cough suppression. It is prescription only, so this is not something that patients can get over the counter, unlike dextromethorphan.
For the most part, the adverse effects are pretty mild. So maybe some dizziness or sedation, maybe even some constipation. But this drug is not without risk. In an overdose situation, this drug can be deadly. It can cause laryngospasm, bronchospasm, circulatory collapse. So, in that overdose situation, even in a situation where the patient is not necessarily overdosing, but they're not taking the medication properly. So, what I mean by that is that this medication has to be swallowed whole. The patient cannot break the capsules, they can't suck on the capsules or chew on the capsules because that destroys the product, and then it can cause some local effects as it's being ingested, and so that laryngospasm and bronchospasm can occur. So this is definitely a drug where you need to provide some education to the patient. Also, this medication needs to be stored away from children, so you have to remind the patient if they're going to be discharged on the medication, or if you're in the ambulatory setting and they're getting a prescription for it, they have to keep this away from children. The product itself, it kind of looks enticing to a child. It's like a capsule that is kind of shiny and bright looking, and so kids may think it's candy, but it's not. And again, even at a typical dose, even if the child only takes a small one tablet of this or one capsule of this, could be deadly, especially if they chew it or bite on it. So this is an important one. I would say it's not something that is prescribed frequently, but it is something that you'll see. All right, and then let's talk about the last drug class we'll talk about are the expectorants. The prototype is guaifenesin, or Mucinex is the brand name. This drug acts by, it basically renders the cough more productive because it stimulates the flow of respiratory tract secretions. So what happens is the patient is experiencing a cough, but they're not able to kind of move those secretions out of their bronchial tree. But since this drug helps to increase the flow of secretions, the patient's actually more able to kind of cough the secretions out, so to speak. The drug is used for cough. That's really the only use for this medication, or the only approved use for this medication. Adverse effects: GI upset, drowsiness, dizziness, rash. For the most part, these are well tolerated. I think the most concerning thing is sedation or drowsiness. Nursing implications: patients should be educated to increase fluid intake, and that's to help increase those secretions in the respiratory tract. Reading the labels carefully, right? So this is another ingredient that's contained in lots of different over-the-counter preparations. And if the cough lasts longer than a week or more, they really should be seen by their provider to be assessed, because it might not be just like related to the common cold. Maybe it's something that there's some other underlying issue that needs to be addressed. All right, so let me just finish up by talking for a moment about over-the-counter cold remedies. I've already mentioned a couple times that these cold products are, in many cases, a combination of lots of different ingredients. They'll have, two or more. Maybe they'll have a nasal decongestant and an antitussive. Some products will have all 5 of these ingredients. Some will have 3 or 4. But the bottom line is, I think the nasal decongestant, the antitussive, and the analgesic kind of makes sense why those might be used for the treatment of the common cold or cough. The antihistamine might not be as straightforward. Remember, I said antihistamines have anticholinergic properties, one of which is decreased secretion, so that's how they can be helpful. Although it's kind of questionable whether they're really helpful in this setting. Caffeine, generally used to kind of offset the sedative properties of the antihistamine in particular, but also possibly the antitussive. The question I have for you guys, think about, this might be convenient for patients to use these combination products, but what does it do to the safety profile? So kind of think about that for a moment. I can tell you for sure that there are issues reported with combination over-the-counter cold remedies. These issues are reported to poison centers routinely. They're reported when patients are presenting to the emergency department, problems with these products get reported directly to the FDA through their MedWatch error reporting program. And what it comes down to is that the issues, it might be more convenient, but in terms of the dosing could be incorrect. If you've got 5 different ingredients, one of the dosing of one of those ingredients might need to be lower for a specific patient, and these are in a fixed combination. So really the question is, number one, do you need all those different ingredients? Number two, are the doses that are in that fixed combination, are they even appropriate for that specific patient? Because those combinations are for most patients, not for your specific patient that might have an individual variation that requires them to use different doses. Furthermore, the patient might be taking other medications that are actually duplicative of what's in the cold medication, and they may not even know it, and that can increase their risk for problems. One of the major issues is risk of Tylenol toxicity. Tylenol and other analgesics are frequently found in these cold remedies, and so the patient may not realize that it contains Tylenol. They might just think it's like Robitussin, guaifenesin, or dextromethorphan. They may not even realize it has Tylenol in it, and they could be taking Tylenol around the clock as well, and that would increase their risk of liver failure, for example. The other population where these drugs are problemsome is the pediatric population. These drugs, these cold remedies, need to be used very cautiously in children. The FDA warns that these should be avoided in kids that are younger than 4 to 6 years old, and in fact never used in children that are less than 2 years old. And really what this comes down to is that there's no proof of safety in this population. First of all, there's no proof of efficacy for these drugs in this population, and there's no proof of safety, and in fact there is a mounting evidence that these drugs are actually harmful in the pediatric population. So the FDA says don't give to kids under 2 years old. They're continuing to study the use of these drugs in kids up to 11 years old. I can tell you the American Academy of Pediatrics has a position statement that says these drugs should only be used, and even in the population of kids that are older than 6, they should only be used cautiously, but they should not be used in kids under 6 years old. If they are used in kids that are younger than 4 to 6 years old, they need to be used very cautiously. But like I said, AAP would recommend not even using them in kids under 6 years old. FDA says never in kids under 2 years old. Because they can cause problems like seizures, hallucinations, impaired consciousness. These are all different adverse effects that have been reported over the years, specifically when kids are brought into the emergency department because they've received these OTC cold remedies, and then they end up with serious problems. If the products are used, they need to be those that are labeled for pediatric use. Healthcare professionals should be contacted before giving these drugs to a kid. Product needs to be read. The safety information needs to be read. The parents need to be instructed to look at all the ingredients and the proper dosing based on the child's age for all those different ingredients. The measuring device that comes with the product should be used. If the child is not improving, obviously they need to consult a medical professional. And then the products that specifically have antihistamine in them should not be used for sedative purposes in kids. Even though there's it would make sense that might be a good thing to do, especially if the child's unable to sleep because they're coughing. But really, this is not recommended. So kind of all in all, these drugs should be avoided in kids. If they are used in kids, they need to be used very cautiously.
So I have 3 case studies built into this particular lecture. I want you guys to look at each case study, answer the questions. The first case study is about a college student who is having some respiratory symptoms, runny nose, itchy nose, sneezing, nasal congestion. Ultimately gets diagnosed with allergic rhinitis. And so look at the case, look at some of these questions, maybe even think of some of your own questions, and we will review this case as well as case 2 and case 3 on our Zoom session, on our next Zoom session. So be prepared with those answers. Case 2, maybe not necessarily something I went over,
but something to think about. So look into this case, see what you can figure out. And then finally, case 3, we talked a little bit about using cough and cold preparations in children. So I want you to think through this case, think about kind of, what would you do if you were the nurse in this scenario? And as I said, we'll talk about these 3 cases on our upcoming Zoom session. All right, and that's it for drugs for allergic rhinitis, cough, and cold. If you have questions, please post them to the discussion board. And thank you for listening.